My name is Kush Desai. I'm serve as one of the assistant deans for the Southwest campus for the Medical College of Georgia. I'm also a practicing internal medicine hospitalist in Southwest Georgia. I'm part of the hub team for the Georgia Colorectal Cancer Control Program. Just so we can get to know everybody, if you can put your name, the name and location of your clinic and your role at the clinic, as well as your email address in the chat. There'll be an example in the chat. And I'll go ahead and do the same. All right. So as you guys are doing that, here's the agenda for today. So if you can do Sema, next slide, please. So we start with an introduction. Then we go into a didactic session and a Q&A, followed by Q&A. Our expert presenter for the didactic session is Dr. Fritz. Then we go into a case presentation. For this case presentation, we're actually doing case questions. And so it's going to be an interactive format for us to learn about the different CRC guidelines. And so we'll be doing clinical vignettes, and then we'll do questions, and we'll hopefully generate some discussion from the audience. And then we're going to go into the conclusions, and we'll talk about how we can get CME for this program. So first, we're going to start with some announcements. So Project ECHO stands for Extension for Community Health Outcomes. The motto is moving knowledge instead of people. Next slide, please. Just some general reminders. These are recorded for quality improvement purposes, as well as we chronicle all of the echoes that we've done and put them online. So anybody can go back and watch any of this to learn any of the information that we went over today. By participating in the sessions, you are being consenting to being recorded, and please don't mention any patient health information since these are being recorded and posted publicly. Next slide, please. This is just a data notification saying that we do record data for the purpose of research and quality improvement. Next slide, please. Just some general Zoom reminders. If you remember to mute your microphone when you're not speaking and to unmute when you do speak. We do encourage questions, so please do ask questions. You can raise your hand. You can put the question in the box. We're fortunate to have an expert speaker with us today, and so please do ask questions as we go through the presentations. Next slide, please. And so now I can introduce you to our speaker. 1 second. So Dr. Fritz is an assistant professor of medicine in the Division of GI and General Medicine at Washington University in St. Louis. Dr. Fritz's future work will leverage local and national population health data to develop system and educational-based strategies to improve CRC outcomes for historically marginalized communities. She plans to use implementation and dissemination strategies to build effective clinical programs with the aim of eliminating disparities in GI diseases. In addition to her GI research interests, Dr. Fritz studies development of academic allied skills for physicians to build more inclusive and diverse academic environments. Her presentation will be on early onset colorectal cancer, earlier detection, and pathways to prevention. So Dr. Fritz, you can take it from here.
Thank you so much for that introduction. I'm really excited to be here with you all, and thank you for the opportunity to discuss some of the work that I've done, and otherwise just thinking about patient progression pathways. I don't have any financial disclosures. Next slide. So a brief outline for my talk today includes patient progression pathway for early onset colorectal cancer, an overview of our work on signs and symptoms and diagnostic intervals for early onset CRC patients, a discussion on opportunities for improvement and the potential for primary prevention. Next slide. Over the last 5 to 10 years, there have been a number of groups who have completed pivotal research to inform our understanding of the risk factors for early onset colorectal cancer. To start, I have to acknowledge the prior and ongoing effort to understand the genetic predisposition for early onset colorectal cancer. But a number of other risk factors have been investigated and include everything from obesity to other comorbid conditions to how we live our lives, including the lack of activity and what we eat and drink. There is emerging data and work to include the gut microbiome and subsequent risk of early onset CRC. But to suffice it to say, this is only a snapshot of some of the prior literature, but highlights the diversity and the complexity of the issues that we will need to address to change the current trends in this disease. Next slide. Despite our growing awareness of the risk factors, there continues to be significant morbidity and mortality associated with early onset colorectal cancer, especially for late stage disease. Younger patients with CRC are more often diagnosed at advanced stages. 27% are diagnosed with distant disease compared to only 20% in older patients. And the 5-year relative survival is less than 20% for patients diagnosed with distant disease. Even for morbidity, early onset colorectal cancer is in the top 5 ranking cancers associated with high disability adjusted life years. So we really want to start this conversation in how to potentially downstage disease from distant to more local and regional stages. Next slide. And considering this, and if we potentially want to move the needle on downstaging to disease to improve earlier detection, we need to focus on the patient pathway to detection. And that's what I'm trying to highlight here. So most studies have focused on steps 3 and 4. Next slide. Leaving us little understanding, leaving us little understanding if there are opportunities to capture patients earlier and hopefully improve the stage at diagnosis. Therefore, some of our recent work actually focused on step 2, patient reporting symptoms to healthcare providers, to determine if there are opportunities to improve diagnostic intervals and or increase awareness of early onset colorectal cancer symptoms to facilitate earlier detection. Next slide. So to do this, our objective when we set out to look at this work was to identify signs and symptoms of early onset colorectal cancer and report the associated diagnostic intervals from 3 months prior to diagnosis to 2 years before diagnosis. We looked at the Market Scan commercial database to look at claims in adults age 18 to 49 years old. And we required that each patient had at least 2 years of continuous enrollment prior to the index date. And that was determined by the pathology date diagnosis of colorectal cancer. We completed a nested case control study, including over 5,000 incident early onset CRCs against matched controls, and then used multivariable logistic regressions and examined the median diagnostic intervals based on the associated signs and symptoms. Next slide. So going back to the previous slide and thinking about working on step 2, we really wanted to focus on this interval, not at the time of diagnosis or even just before the time of diagnosis, but 3 months prior to back up to 2 years prior to this diagnosis. And what we found when we looked at a number of symptoms, it was totaling 18 to 20 symptoms to start with, we found 4 red flag signs and symptoms that were associated with development of early onset colorectal cancer 3 months to 2 years prior to the index date. And those were abdominal pain, rectal bleeding, diarrhea, and iron deficiency anemia. We took this a step further to think about if whether or not having multiple symptoms potentially changed your risk profile, and found that with each additional sign and symptom, you had a 91% increased risk of having early onset colorectal cancer. Next slide. So to try to understand this further in the sense of time, we took 3-month intervals going back all the way from 3 months to 2 years to 21 months prior to diagnosis to 2 years, and found that these signs and symptoms were still significant for the development of early onset colorectal cancer up until 18 months even prior to diagnosis. Next slide. And finally, to understand the importance of that large time interval for the duration of signs and symptoms, we looked at having any sign and symptom 3 months to 2 years in cases only, and found that the median time to diagnosis for any type of sign and symptom that we found in our study was 8.7 months, with quite a large range there, as you can see. And then divided this further in understanding how that interval changed based on the type of symptom that patients were reporting to their providers, with the longest interval being for abdominal pain at 11.7 months, and the shortest one being for rectal bleeding at 7.1 months. One of the things that we thought was still pretty interesting is that even for iron deficiency anemia, which most of us do associate with an increased risk of colorectal cancer, for this younger population, if they reported only iron deficiency anemia, that they're waiting somewhere around 10 months from the first reporting of their symptom to their actual diagnosis. We wanted to understand if people were reporting more than one symptom, either 2 or greater, 3 or greater symptoms, how that changed the diagnostic interval. And it did shorten it for all of the symptoms. But even for things like abdominal pain and iron deficiency anemia, by the time patients reported both of those symptoms, they still waited just under 8 months prior to diagnosis. Next slide. So just taking a step back and looking at our current preventative approach, with the increasing incidence of early onset colorectal cancer, the screening age was lowered to 45 years, which we think is a really great win for this younger patient population. But it's really important to remember that 50% of early onset colorectal cancer cases are actually diagnosed younger than 45 years old. And when we look at this younger population, even for people who are 40 to 49, the screening uptake in these individuals has been slow. And, highlighting that we are not capturing everyone by screening. Next slide. And there's been a lot of discussion, especially with some of the newer guidelines by the American College of Physicians coming out saying we should still keep screening at 50, whether or not we have the resources and the ability to do this lift for this younger population. And so there was a really nice study that looked at what that lift actually amounted to. And we think that based on a number of assumptions that were made in this study, that by lowering the screening age to 45, we need to screen 20 million more people, which is a lot. And that increases our average risk screening pool by about 60%. Next slide. So a number of people have really asked the question, do we have the resources to do this? And what I can show you is that when you look at how people are screened over a number of years, that the majority of people in this country are screened by colonoscopy. But there is still a very small portion of people who are doing stool-based testing. And there was a recent study in CGH that looked at what is this younger patient population, what are they interested in, how do they want to be screened? And so there was a questionnaire about preference for CRC screening tests among 1,000 unscreened Americans, and found for this younger population, 40 to 49-year-olds, that almost 70% of them actually prefer stool-based testing. And I will argue that the only way that we are going to get to the 80% screen for the overall population is if we leverage our underutilized resource of stool-based testing. Next slide. And when you have these conversations with your patients about if there really is a difference between stool-based testing and colonoscopy, I think it's very important to talk about all of the differences between both of those, and how colonoscopy can be not only diagnostic, but therapeutic and remove polyps at the same time, all of those same conversations that I'm sure most of us have. But when you look at the data about whether or not there's truly a difference between colonoscopy and FIT in additional cases averted of colorectal cancer, there's really not. And I think that we can share this data with our patients to encourage them, if they're hesitant about colonoscopy or they just have a preference for stool-based testing, that they can feel confident that the data shakes out pretty much the same, whether you're going to look at colonoscopy or FIT every year, even at this younger age population down to 45. Next slide. And one of the other things that I just want to highlight, this is not something we have adopted within the United States, but we can look to our British colleagues, and this is a guideline that comes from the British Society of Gastroenterology that has started using FIT as within their diagnostic pathway. So one of the many arguments that we have discussed and heard when we moved the screening age down to lower to 45, or we started talking about these signs and symptoms, and people were saying, well, am I supposed to screen every single person that has abdominal pain? And that is not what our data supports or what we're even advocating for. But what we are trying to say with our most recent study, looking at the signs and symptoms of early onset colorectal cancer, is that we really need to think about that patient progression pathway. And are there ways to potentially risk stratify people with stool-based testing? So what the British guideline does is within the primary care setting, they've looked at different levels of FIT using 10 as their benchmark. And if it's positive, they get placed on an urgent pathway for colorectal cancer investigation. But if it's negative and then there's ongoing clinical concern or unexplained symptoms, really going back to close that diagnostic loop to see if symptoms resolve and they can still stay in the primary care setting. Or if your suspicion is high enough, still referring them on an urgent or routine pathway to endoscopy. The other interesting part of this study was they looked at the different levels or thresholds for FIT testing. They used 10, as you can see here in the second column. But what they found was the number of people that they needed to scope was only 10 by using stool-based testing to help within this diagnostic pathway. And they only missed one cancer by utilizing in 1,000 people by utilizing FIT to help triage cases. Next slide. And lastly, just thinking about primary prevention and going back to mitigation of risk factors, especially in the primary care setting. I know a lot of time goes into just trying to talk to people about healthy lifestyle, including decreasing metabolic comorbid conditions, including obesity, and thinking about improving physical activity and decreasing alcohol. But there are likely opportunities that'll be forthcoming about thinking about chemopreventative agents for early onset colorectal cancer. Next slide. So to investigate this a little bit more, we are currently working on a study utilizing the Nurses Health Study 2, which in totality includes over 100,000 women that starting in 1989, age 25 to 42. And it has asked women a number of questions, including their aspirin and NSAID use every 2 years and whether or not they've had lower endoscopy, and they fill these surveys out every 2 years. And from this cohort, we were able to look at a sub-cohort of over 30,000 women who had a lower endoscopy before the age of 50 between 1991 and 2015 with the exclusions I've listed here. Next slide. And what we found was that women who reported regular use, which was defined as 2 times a week or more of aspirin or NSAIDs, and the associated risk of early onset adenoma as a precursor to early onset colorectal cancer was significantly decreased by about 16%. We also wanted to look at whether or not that changed by malignant potential, histology, and size. And although the our P for heterogeneity was not significant, we did see this signal within histology, specifically being more protective for villous adenomas. So from here, what we did was look at just women at their first endoscopy, because this data set can include women who have undergone multiple endoscopies and therefore are on a screening or surveillance pathway. So next slide. What we did for people who are just undergoing their first endoscopy under the age of 50 and looking at prior regular aspirin or NSAID use, and found that that was associated with a significantly decreased risk for development of villous adenomas that was different than a tubular histology, as you can see here in the middle, which we found interesting, and we're continuing to explore this data a little more. Next slide. I think what we can draw from this so far is that regular aspirin or NSAID use, defined as 2 times a week or greater, what we did find an association with a lower risk of early onset adenomas, especially those with advanced histology. But future work really needs to evaluate this as a promising agent for chemopreventative chemoprevention for early onset CRC. And we really need to think about racial and gender diversity, dose and duration of young adults, and other precision-based strategies. Next slide. So to really move the needle on early onset colorectal cancer, and curb some of these worrisome trends that we're seeing within these younger patients, we need to take a multi-pronged approach, which is going to need to include increased inclusion of minority populations into research and different dissemination and implementation strategies. We need to consider risk prediction models that incorporate not only family history, but social vulnerability, risk factors, and genetics. And we really need to start changing the conversation to increase awareness of early onset colorectal cancer and the associated signs and symptoms, and figure out how to target resources to the patients who need it most, both at the system and population level. Next slide. So in conclusion, next slide, you want to hit forward? We need to increase awareness in the public among both providers about the signs and symptoms. We need to encourage patients to seek care when they're experiencing the concerning signs and symptoms. As providers, we need to listen to our patients and make sure we're closing the loop. If there's no resolution of these symptoms, starting a diagnostic pathway early to endoscopy to hopefully get an earlier diagnosis and decrease diagnostic intervals, and potentially utilize FIT as a risk stratifying step within this diagnostic pathway if you're kind of on the fence about certain signs and symptoms. And always remember that urgent endoscopy referral when your suspicion is high. And finally, always going back to prevention, thinking about risk factor mitigation, especially with those comorbid conditions, leveraging aspects of chemoprevention, I think are something that we're going to need to think about in the near future, and really trying to utilize more stool-based testing so we can increase the amount and number of patients that we are screening within this country. Next slide. And just to acknowledge my mentor, Dr. Yin Cao, everyone in our lab, and our funders, and I'm more than happy to take questions.
Thank you, Dr. Fritz. That was really interesting. I know I heard your talk at NCCRT a few months ago, and I saw you added some new information, which was pretty cool to see as well with the aspirin and the NSAID. So Dr. Hotz looks like he has a question. Dr. Hotz?
Yes, once again, a fantastic presentation, and I was at the NCCRT and glad we got you on board to kind of take this to our home team here. Big challenge we always run into is people come in and say they've had rectal bleeding, one time, 2 times, and, very commonly associated with hemorrhoids, but if you do an exam, or if they say they're not having hemorrhoids and they're, 38 years old, it would seem to me that you'd have a high likelihood or want to consider strongly a colonoscopy, because I see these things like you showed go on for years. And the second thing is iron deficiency anemia in somebody going through menopause where they're having heavy menstrual periods. Almost always people get put on iron and say it's the menstrual, but I know we miss a lot of people. So it seemed to me a strategy of a FIT test in them would make a lot of sense, but it's not common practice. So those are very common, and we sit on, oh, it's hemorrhoids or they had a hard bowel movement. And, it seems to me that a far more aggressive approach makes a lot of sense. And your thoughts on that?
Yeah, I know those are really great comments and questions. So my day job is being a GI hospitalist, and the number of people that I scope in the emergent setting that are young, who have been told they've had hemorrhoids for the last 6 months to a year, and I end up diagnosing them with colorectal cancer, is not lost on me. So to your point, I think that what we do from a risk perspective of colonoscopy is very low risk. So if someone is young and they have continued rectal bleeding, let's put them on that diagnostic pathway so that we can be reassured that we're not missing something, and they can be reassured that it is just hemorrhoids. As far as the iron deficiency anemia, I am really interested in this data specifically for that, because anecdotally, you hear a lot of young women who have been diagnosed with colorectal cancer that they're told, well, their iron deficiency anemia doesn't matter because they have periods. And within our data set, at least, the iron deficiency anemia was still predictive, even when you stratified by gender. So I think, to your point, that not ignoring iron deficiency anemia just because someone's, has menses makes sense. And they should still have some type of diagnostic pathway, whether that be a FIT or whether that goes straight to endoscopy, depending on your resources and your own setting and the patient's ability. I think doing something to risk stratify them further makes sense.
Thank you. Great comments.
Thank you. It looks like we have a question for me. So it just says CRC co-host. So whoever has the question, you can just go ahead and ask it. It doesn't give me a name.
Oh, okay. I have a question about the interval, the time from when the patient reports that they do have a symptom to when they actually diagnose. You had a good slide that showed the months for the different ones. My question is whether, do you think if you stratify that by insurance status, that you have a difference in the length of time?
Yes, but we don't have that data. So I've thought about reproducing this study within the Medicaid national data set population. One, because that will give me race. So Market Scan doesn't have race, which is really frustrating. And two, to understand if those diagnostic intervals are, as we would expect, longer in people who have less access. I suspect that to be true, but I don't have the data to support it.
Okay, great. That would be interesting to know. Thank you.
Thank you. Any other questions for Dr. Fritz?
Well, I do have a question on slide 18. I don't know whether we can get there. It's basically showing the very low screening rates across the board by age and different types of screening tests. And Dr. Fries mentioned something about that based on experience, challenges that we have, insurance, human factors, economical factors. Do you have any suggestion for us that we can take into and work towards to, not this one, the next, it's
Are you talking about the low screening rate in the 40
low screen,
to
like
49?
40 to 49 and 50 years above? The colonoscopy was 40 to 49, 31%, 22%. That's the slide. So you mentioned something, leveraging our resources. So I wanted to see your take on it, how we can, leverage. What are the things that, our tools are limited.
Yeah.
So,
Yeah, no, that's a really great point. My whole kind of like song and dance is that we should use stool-based testing. I love endoscopy. It's why I went into GI, but I think if we're actually going to help the masses, we need to use more stool-based testing in this country. And what the preliminary data shows is that this younger population is actually more interested in stool-based testing. So FIT is cost effective. It is cheap when you think in the regards of everything we do within the healthcare field. It's hard when you get into situations where someone doesn't have great insurance and they have a positive FIT. So understanding your own ways and within your own system to get people resources still, if that happens, I think is really important to know prior to handing out FIT to people that might not have the current resources or current insurance to get colonoscopy if it's positive.
Makes sense. And Dr. Hotz looks like he has a question as well.
Yeah, I have one question. I wanted to hold this back. I'm a master in American College of Physicians, and then our state gets asked to respond to new guidelines from ACP. When they talked about moving the age back to 50, we put a strong response from Georgia saying that doesn't make sense based on the data. They came back and had a conference and also had a session where we could make comments. And they said that one of the main reasons they do that is because there's not been a randomized controlled trial showing that screening at age 45, is of benefit.
Yes.
And so what is your response to that argument? Because I know we do a lot of things where we don't have randomized controlled trial. The U.S. Preventive Services Task Force requires pretty extreme evidence before they will make a recommendation. How should we respond to that? Because we have colleagues now, within our own group in which it's a bit of a fight on the 45 versus 50.
Yeah, I'm biased because this is like my area of research. So let me just preface my statement with that. But I don't agree. I think that if you look at the increasing incidence and the trends and even the projections for where this is going for younger patients, screening people at 50 or screening people, having that delayed, because even though we say 50, right, the majority of people take somewhere between 3 to 6 years to get into either a primary care physician to get stool-based testing or into an endoscopy suite. So delaying that even further just doesn't make any sense to me. But I hear what they're saying. They like this certain level of quality of evidence, but I don't think we need a randomized control trial to prove what we see every day. And I think we have enough great data. Now, granted, some of that is like micro simulation data, but we do, those are really sound studies, even though it's micro simulated data. And we've made a number of guideline recommendations based on similar data that have been supported through years.
Thank you.
Yeah, thank you, Dr. Fritz. We were all kind of confused. I'm also an internist too, so we were all kind of confused when that came out, and we were just kind of banging our heads in the wall because we're going backwards now. And so I'm glad that you were able to clarify that for us. So for the next section, we're going to go into some clinical vignettes. So this is something different. We haven't done this before, but this is a way of reinforcing some of the concepts that we've gone over the last year and a half. And so a lot of these questions will be easier, but hopefully some will generate some discussion and help reinforce some of the points that we've been making throughout these sessions. So I might call out, I see that there's some of my providers that from our East Georgia and from APHC clinics. So I may be calling out just to get your opinion on some of these clinical vignettes. So don't feel embarrassed. I mean, there's, if the answer is wrong, no big deal. We can always talk about it. All right, next question, or sorry, the first question. All right, so I'll read the question and somebody just shout out the answer and then we'll just go from there. We were going to do a poll, but unfortunately the iECHO platform didn't allow us to do polls. So we're trying to work with them to see how we can incorporate that into Zoom. So at this time, we're not going to have a poll. We'll just go the old fashioned way. So first question is, Mr. Brown is a 47-year-old accountant, walks into your office for his first regular checkup in a few years. He's had no significant medical history, has never smoked, and enjoys cycling in his free time. He has no family history of cancer and is currently not experiencing any health issues. He has never had a colonoscopy or any other type of colorectal cancer screening tests. Yeah, that's true. Or you can just put your answers in the chat. That may be an easy way to do it as well. And so either just call it an answer or put it in the chat and then we can discuss. All right, very good. All right, looks like we've made our point very clear over the last year and a half of that. It is a very good option, and Dr. Fritz did a really great job explaining why that's the case and how the person, the mortality benefit is very similar for FIT if done yearly compared to colonoscopy. Now, of course, the other point to make here is that it says urgent colonoscopy, and so urgent colonoscopy would be in the case of especially like we just talked about a few minutes ago, if the patient has rectal bleeding and anemia, that would be a reason to do a more urgent, maybe not emergent, but urgent colonoscopy because that patient might actually be already have cancer. And so good job, everybody, on that one.
Can I make a comment?
Sure.
Well, I looked into the chat answer options. They're all B's. So there is no confusion. So I think this group learned very well.
Yeah, this is a smart group. So they've been with us for
yeah. So I think
the questions do get a little bit harder as we go on, though. This was a little bit of a softball, but the group's been learning really well. We've done this for over a year and a half now. So
Coach, could I make a point there?
Sure.
It's the exact scenario that was presented by the ACP when they had their update about changing that.
Hmm.
And if you answered that thing, which is what I answered,
Yeah,
it was wrong.
that's
You know,
crazy.
you're supposed to go into informed decision making and, you know, a lot of other stuff. But, you know, that was their response by the excerpts they had there. Now, they had a GI guy speaking saying they disagreed.
Yeah,
But you know,
yeah.
that's the, you know, that's the
That's a
challenge.
good point, though. That's a good point. I mean, you want to give the patient the best opportunity to prevent cancer. And so if you want to do what's best for the patient in this scenario, I mean, you need to recommend that you are at a higher risk because, you know, we're seeing younger patients with colon cancer. And so probably this is the option you should take. I mean, I wouldn't go into a shared, I would go into this is the recommendation, but you're absolutely right. The ACP, for some bizarre reason, is doing that. So next.
Koosh, for the
Yes.
record, I only got it right because I looked on Dr. Hotz's paper.
All right, next. All right, so Miss Green is a 41-year-old software developer, comes to your office. She has a healthy lifestyle, but her father was diagnosed with colorectal cancer at age 52, which worries her. She is currently asymptomatic and hasn't done any colorectal cancer screenings before. Which would be her best method of screening for her? Or what would you do next? So would you do a FIT now? Would you do a colonoscopy now? Would you do or I should say schedule for a colonoscopy now? Would you wait until 50 to begin? Or would you recommend Flex Sig? Or would you wait until 45 to begin? That's another option that we could also consider. Very good. So everybody is saying B, so that's good. Does anybody, so next slide, please.
Coach, before you
Yeah,
go
go ahead.
next slide, would you mind to explain, because I know everybody.
Well, the next slide has the explanation.
Okay, okay.
Yeah, that's why
Okay, go ahead, please.
Yeah. So this is a patient, the first thing to consider is this is a patient with high risk because it's a first degree relative that has cancer. Can you do Summa or Chris? There you go. All right, so this is the U.S. Preventive Task Force recommendations. This is like the government recommendations. This is for high-risk patients that have a first-degree relative with colorectal cancer, or sometimes we forget this, we could have made it a little bit trickier, or a documented advanced adenoma. And so it's colorectal cancer or advanced adenoma, which is, of course, high risk of progressing to CRC. Or if you have two first-degree relatives with CRC and or documented adenoma, the key here is you start with screening with colonoscopy at age 40 or 10 years before. Does that make sense? Age 40 or 10 years before. And so if the age of cancer diagnosis for, let's say, somebody's father was 45, you would actually start at age 35, according to these guidelines. And so that's really something important to keep in mind. And as we take family histories on patients, it's something to always remember. And sometimes, let's say it gets confusing if, let's say, they got diagnosed at age, you know, somebody's dad got diagnosed at age 57, the answer would still be starting screening at age 40. It would not, so it's 40 or 10 years before, whichever is earlier. And so the key part is whichever is earlier. And we also recommend, and this is also important, starting with colonoscopy, but if you look at recommendation number 4, and this is actually strong recommendation with moderate evidence, is if they have, if they don't want colonoscopy, you should still offer them a FIT. And so it shouldn't be colonoscopy or nothing in this patient. That is something that is important to remember, because a lot of our patients don't have the opportunity to get a colonoscopy. A lot of our patients, especially in these underserved areas. And so that's something, kind of 2 very important points to keep in mind. Does anybody have any questions about that or clarifications or anything?
No, just wanted to add a comment on that because if patient, Dr. House mentioned earlier, informed consent patient do not agree with the colonoscopy, then we go for at least for the FIT test. And then again, it's an screening test. what if fit test come as a positive and patient do not have health insurance? So that would be the dilemma for the providers, because ethically, if you do not screen someone unless you can provide some form of
Good.
resolution or treatment
Yeah.
management. So
That
that's
is true.
yeah.
Yep, that's a good point. Luckily, a lot of hospitals, including the ones we work with, if you have a positive fit, they're more likely to go through their patient assistance program. But you're right, it's not 100%. You know, it's not always the case, but that is more likely to happen. Next slide, please. Next question is, we have a 60-year-old retired police officer comes for a checkup at age 55. He's had adenoid polyps removed during colonoscopy, but since then he's been in good health. He doesn't smoke and tries to stay active by walking daily. What is your next step? So do you want to schedule a colonoscopy in the next 6 to 12 months, start an annual fit test, recommend Flex Sig, or don't wait another 5 years for the next colonoscopy? Oh, sorry, wait another 5 years for the next colonoscopy.
And we can hear from the audience the reasons why we chose A. Why did you choose A?
Looks like everybody likes the question, or likes the answer A. Very good. So these, this is something more, I guess it's good for primary care to know these guidelines as well. This is more something that the gastroenterologist, when they do when they remove a polyp, they'll typically tell us when the next colonoscopy is due in the next interval. But if you go to the next slide, this is just something to kind of keep in mind, because it is important that sometimes, oftentimes, the patient gets lost to follow up. And so if you have a colonoscopy report in hand with the pathology, you can use these guidelines to determine when the next surveillance screening is. This is different than your not your screening. This is when your next surveillance colonoscopy is different than your screening colonoscopy. Because these patients are at higher risk. And so just as an example, Dr. Fritz probably has these memorized, but for the rest of us, I have to just go back to the guidelines myself and then just kind of see. Dr. Hotz has his hand raised.
Yeah, and I'm directing this question to Dr. Fritz because the biggest complaint we see nationally, and I chair our national community health center colorectal cancer screening group for the National Roundtable, is we don't often get the recommendation, because these are what's there, but sometimes there's a poor bowel prep or inadequate. They didn't get a good look. They're not absolutely certain. So in the report, they may suggest repeat in a year or repeat in 2 years. So they don't always follow the guidelines. And it's always helpful to have that in the chart so you can actually date the next one. But it's sometimes difficult to get that. And I know the GI societies nationally have been trying to work on this. Any update, Dr. Fritz? And, have you run into that as a concern from the primary care people that use your services?
Yeah, absolutely. Because I think, depending on where you look too, they're similar, but there are differing guidelines. So if you look at the AGA guidelines, they're the ones that you'll see that like 7 to 10 year. I don't know if any of you have seen reports that now say 7 to 10, which have been confusing patients and primary care providers too. That's the main difference between these two. So what we have been doing is we basically created a dot phrase that we use at all of our endoscopy reports that basically give if-thens, so that the primary care providers know when to send them back or know when to ask, have specific questions for us if the reports don't make sense. And then we'll go through, mine is very long, because it'll be 1 to 2 polyps, you do this. If it's serrated, you do this. If, so you have all of these if-then statements so that you can look at the pathology and then match it with my report. One of the other groups that is not our large BJC WashU group, but they're on the West Coast. What they're doing is going back and asking all of their GI physicians from a systems perspective, once they get pathology, to update the reports, update the endoscopy reports. that way to like completely close the loop for patients and providers.
Thank you.
Sounds good. Thank you, everybody. So next slide. I think we have one more question. Okay, so this is a 6-year-old female patient presents with a history of non-compliance to regular medical screenings and has a general aversion to tests, has no personal or family history of colorectal cancer. How should you proceed next? So you advise for colonoscopy immediately? Do you suggest a sigmoidoscopy every 5 years? Do you recommend a FIT annually? Or do you advise for a stool DNA every 3 years? So what are people's thoughts, or what would you do in your practice? We have some D's. Okay. A and a D. A, we have another D. A. All right, so it looks like a lot of A's and a lot of D's on this one. All right, so that's a good got some good good discussion. We got kind of a split between A and D, and so technically this was a trick question, so technically any of them could be correct. You could, so the guidelines say you could do there's the screening options include colonoscopy, FlexSig every 5 years, although that one is not really utilized very often, and sometimes misses the right side of the colon, and you still need prep, and so it really doesn't make a lot of sense, but it is part of the guidelines for U.S. Preventive Task Force. There's FIT annually, or it's a stool DNA test every 3 years. So a lot of people liked the colonoscopy and the stool DNA test every 3 years. And so stool DNA is, of course, Exact Sciences product, Cologuard. So technically, I mean, a lot, C could also be correct. Now, for a patient that has missed screening for 15 years, personally, I'm going to try to get them the colonoscopy if I can, if they're okay with it. I don't know, Dr. Hotz, what are your thoughts on that? What do you typically do if somebody's been unscreened?
It's a harder sell. And then you've got the loop of getting them to do the bowel prep if they're non-compliant, show up. Now, we have very strong navigation, but it's not available everywhere. So our Horizons navigation, they can, get a show rate of 80% for colonoscopy for uninsured people. That may be what we would do. But generally, and this is something we're looking at, the ability to do a FIT test every year in a community health center population is difficult because a lot of them don't come in every year. They get lost and they're hard to find. So, something that covers you for 3 years makes sense. We're actually doing a project with Exact to try to see, because they've now removed some of our barriers for cost and that. And so, every 3 years is better than every year. A colonoscopy could be great if we could get it, but, probability of getting a stool test back that's navigated, by Cologuard versus a colonoscopy, so it's a tough call. It's a tough call. You just have to know the patient and, as a primary care doc, but if they're not seeing you regularly, you probably don't know them very well to begin with. So these are challenging patients.
Yeah, that's a good point. Dr. Fritz, what are your thoughts? A lot of people have had the Cologuard option. What are your thoughts on that product?
Yeah, I'm not a big Cologuard fan personally. I understand why it's used in the primary care setting, especially in like this situation where you're trying to increase the interval that somebody needs to get screened. The only reason I say have the stance that I do is just related to cost. You get very little benefit other than the extension of time And it's significantly more expensive for the system and for the patient. But if you have the opportunity to decrease those costs with partnerships, I think, using Cologuard and vulnerable patient populations makes sense. I would say the only one that I would not do out of these four would be the FlexSig.
Yeah.
Some of our GI guidelines have really gone away from offering flexible sigmoidoscopy as a screening measure, just because we're totally missing the right colon, and we know that we have an increasing rate of right-sided lesions now.
Yep. No, that's fair. And I don't in our working in this grant, hardly anybody. I don't think anybody has ordered a FlexSig in any of the patients we work with. So it's really out of date. So, all right, very good discussion, everybody, and hopefully we all learned some stuff. I know I did. Let's do a next slide, please. So if y'all have any final questions for Dr. Fritz, so while we still have a couple more minutes and we have her expertise with us, if anybody has any final questions.
I just had one clarifying
Sure.
question about the figure you cited about 50% of the younger people getting it before age 45. So does that mean the other 50% is between 45 and 50?
Yes. Yep.
Okay.
So half of that early onset population is within screening range, and the other half is actually not in screening range.
Okay, just making sure it did cut off at 50. Thank you.
And I've got one final question with Dr. Fritz. We've been chasing family polyp history for 20 years. And I'll just tell you, I've had, 6 of these things. My dad died of colon cancer. So I've had 6 colonoscopies. I got 22 polyps, and I got a bunch of doctors in my family, and nobody knows their family polyp history. Is there any tools developed to help, really solidify that? Because, there's hyperplastic polyps, which, carry no risk. And then there's other ones. So, I know it's out there to do, but, I don't know if anybody is doing it in the primary care world, at least the one I know.
No, you bring up a really great point. And people do not know their family polyp history, because we can barely get people to remember whether or not somebody had colorectal cancer. So there are some opportunities that people have talked about, and how do we streamline the Provation or Epic, whatever you use to document your endoscopies, but it would need to be on a national platform that everyone would have to share. And there's been all sorts of pushback around that. So I think until we get platforms that we can actually share this data and link families, it's going to be up to know their family history. And although polyps are important, as you pointed out, not all polyps are created equal. And trying to have people who are not gastroenterologists or even not physicians understand all that, I think, is way too big of an ask for patients. So really focusing on the cancer history to start.
Very good. Thank you. And thank you again, Dr. Fritz. You have really a gift of taking really complex topics and making them really easy to understand. So we really appreciate that. I noticed that at the NCCRT. So thank you for joining us and telling us, giving us all your knowledge, a little bit of your knowledge, I should say, in a very short period of time. So, so next slide is for CME, CNE. And so Dr. Islam is going to go over this.
Thank you, Dr. Desai. We bring benefits to the participants for our CRC project here. Those who participated today in the session, we have CME credit for you. If you would like to claim your CE credit, please follow the link posted on the chat session. And before I going further, I wanted to update that we have sessions every month. First 1 month we have our CME, the other month without CME. And thank you, Dr. Desai, for leading us through this session today. And I wanted to thank you, Dr. Fritz, for your wonderful presentation. In fact, as Dr. Desai mentioned, that it's a very complex and difficult topics, and you made it easy for everyone today. And for moving forward, we would like to have volunteer present our case presentations for our future sessions. If anyone has a particular case would like to bring up, please email to us at au_crcscreening@augusta.edu. Our next session in April 3rd, 2024. We will share flyers with the information in our next session within 2 weeks from now on. And we really thank you for all the participants for your wonderful participation and participating in the QA session. I think this session was new for us, and I think it's very productive and informative for all the audience. Thank you, everyone. Have good luck and good evening.